So in Australia, our culture is to cultivate awareness and respect for our traditional culture and heritage through an acknowledgement of country. So I would like to extend the acknowledgement to the traditional custodians of all the lands on which we gather today. We pay our respects to current leaders emerging for their spiritual connection to place, to the land and water, and for nurturing these over centuries. Next. So good morning. As Inga indicated, my name is Dr. Colleen Cheek, and Professor Holger Pfaff has kindly joined us today for a conversation about inspiration of resilient performance in organisations. Professor Pfaff is the Director of the Institute for Medical Sociology, Health Services Research and Rehabilitation Science, as well as Director of the Centre for Health Services Research, Cologne. He is also chairman of the board of experts of the German Innovation Fund, appointed by the German Federal Minister of Health, and a spokesman of the Association of Professors Teaching Health Services Research at German universities and Universities of Applied Sciences. Professor Pfaff is also an elected member of the review board of the German Research Foundation for the subject area Public Health Services Research, Social Medicine, and a member of the Task Force for Palliative Care of the Leopoldina National Academy of Science. Wow. I'm not quite so prolific. My name's Colleen Cheek, as mentioned. I'm a senior research fellow at Macquarie Australian Centre for Innovation in Healthcare in Australia. I have over 30 years professional experience in healthcare, and my interdisciplinary expertise spans medicine and nursing education, health system reform, workforce capacity, and information systems. I've recently returned to academia from the acute health sector, where I held a senior executive role for 3 years over the global pandemic. Holger and I began a wonderful conversation on the bento box lunch steps at the August ISQA conference in Seoul this year. Having just come from the acute sector, I was really concerned. Battling systems that seemed not to listen, did not seem to have a plan, and did not seem to act nimbly. My clinical colleagues were fed up, and some were becoming unwell, some were leaving, and others just seemed stuck. Next. So early recognition and response to acute patient deterioration is a quality safety initiative in hospitals internationally. This is based on consistent evidence that in a significant number of adverse patient events, measurable changes preceding the event were evident and could be acted on to prevent harm. Similarly, unwarranted clinical variation is something we monitor to pick up trending downwards and unwanted variation, and we take action to remedy this. Now, while this focus on patient safety is irrefutable, delivering safe, patient-centred, high-quality healthcare requires a workforce that is functioning at a high level. Mounting literature reports hospital clinician burnout characterised by emotional exhaustion, depersonalisation, and a sense of low accomplishment. Clinician burnout is costly for the individuals and for the organisation. Clinicians suffering burnout perform poorly, teach poorly, and may leave the profession. The individual may suffer a loss of professional efficacy, anxiety, and depression, and suicide. Individual factors may mediate the effects of poor work environments, but only to the point that the demand does not exceed the resources. It was my experience that, like patient deterioration and unwarranted clinical variation, the signs of a faltering workplace are evident before clinicians burn out. And I proposed to Olga that we could monitor systems to identify failure early and intervene to preserve the workforce that we do have, and also to rescue faltering systems before further harm is done. But what are reliable indicators, and how can we enact them? So serendipitously, I was introduced to Holger at ISQA, and so began our conversation. Needless to say, I think we could have continued all day. So without further ado, I'll hand over to Holger to steer us further along this journey with some of the work he's done. Over to you, Holger.
Thank you very much, Colleen. I will use my slides to hold a short presentation. Do you see the slides? Okay. And yes, the point is, this is only one, I will present the results from the survey on research in COVID times, but it's more about what you said, Colleen. It's about what are the basic resources healthcare organizations can rely on during crisis, but also during normal times. So as you said, burnout is also, it's not only a symptom or a result of crisis, but also of normal routine work. So, and my interest is in what are the basic requirements, what are the general performance resources for healthcare organizations. And I will present here a more sociological approach. It's a Parsonian approach from Talcott Parsons, which helps us perhaps to identify more these basic resources we need to cope with normal conditions and with extraordinary conditions. So, and here it's about preventive resilience. I will go further on. I hope it will work. Wait a minute. Yeah. Yes. So the background is that the COVID-19 pandemic produced environmental uncertainty, and we did research on long-term care organizations, and they had to manage two problems during COVID-19, and these are the routine demands. I would say that's the normal case. Healthcare organizations are high reliability organizations, so they have to be really good in doing the routine. That's the main task. And but if there is some additional demands like COVID is only an example for any type of non-routine demands, in my opinion. So we have to distinguish between routine demands and non-routine demands. And often if there is nothing changing and nothing happened, the healthcare organizations have only to cope with routine demands. But if there is something happened outside, like the COVID-19 pandemic, or, for example, new innovations within the hospital, then we have non-routine demands. So this is a quite general model to distinguish between routine demands and non-routine demands. And we are looking now at the pandemic-related non-routine demands. So it's about the quarantine zones, the test procedure, the vaccinations, and all the problems the long-term care organizations have had during COVID. And the normal demands of daily routines are staff shortages, remuneration, restructuring, and so on. So double burden on the long-term care organizations, and the preventive resilience means that there are resources within the healthcare organizations which help to diminish the demands posed on the healthcare organizations. And the demands you see in the models are, as I said, routine demands and the non-routine demands. For example, in this case, the pandemic demands. And the question is, what does these demands, what are the results of these demands? You see the outcomes. And like Colleen, you said, burnout could be that's the health of employees. So the question is, do the burnout rates rise up within the long-term care organizations? What about the person-centeredness of the care, and so on? And what about the resilience of these organizations? So, and we are looking now more I'm looking more on the agency capacity of these long-term care organizations, and the agency capacity is basically basic resources. I will show you this. It's about the capacity to act. And Talcott Parsons has his agile scheme. Within his system theory, he points out that every social system, basically he says every system, but we are looking now on social system. Every social systems have to be adaptive. That's the A in this agile acronym. The G is the goal attaining function, and the I is the integration function, and L means latency that is sustainable. So agency capacity could be defined as a capability of a healthcare organization to be adaptive, goal attaining, integrative, and sustainable. So to get to your notion, Colleen, are there any indicators for early detection of problems? I would say yes. If these resources here, the integration resources, if they are lacking in healthcare organizations, if we see that there are deficits in goal attaining, in integration, then I would say there are early indicators for problems with burnout and other things. There are, for example, to point to one thing, integration means, in my sense, if I translate integration into the measurement, we would, and we have measured here integration with social capital. So if the social capital is high in healthcare organizations, the integration is high. So there are no disputes. There is a we-feeling, there is trust within a healthcare organization if the I in this agile scheme is high. So, and we know, Colleen, that, and we did research on it, that if social capital is high, burnout is low. So now, if we measure social capital, for example, and we see a deterioration in social capital, we would predict that burnout would deteriorate too. That is one point. And we did also now we just want to publish a paper. We could with this agile scheme we can predict quality deficits in German hospitals in a 10-year time span. So we measured it in 2008, and we can predict the quality deficits in 2018 of these hospitals. So it's this construct is quite, I think, mighty. So, okay, and what is preventive resilience? It can be defined as the ability of a healthcare organizations to avoid or diminish stressful routine and non-routine demands. So it's about lowering the input into the system. And so it's about preventive resilience. It's then about the total amount of demands. So it's non-routine demands plus the routine demands, which is relevant for the healthcare organization. And we out of a system theory perspective, we would predict if the demands are quite high, the probability that burnout is occurring in these healthcare organizations is also quite high. So it's really also a matter of health promotion if we diminish the demands. So what have we done? This was an online survey of long-term care organizations and for managers from outpatient and inpatient nursing and palliative care organizations in Germany. And we surveyed them 2 times in April 2020, directly after the declaration of COVID-19 pandemic. So it was the first wave, was also the first wave of COVID. And we did a second survey between December 2020 and January 2021. That was during the second wave of COVID. So, and we measured, as you can see here, we measured the pandemic-specific demands, as you see here. So it was about so for example, the acquisition and utilization of infection control equipment, does it affect us? Has it a burden on us? And so on. And it's about infection among care recipients, about infections among employees, and testing problems, isolating people as a problem, compliance problems, and so on. This measure has a Grombach's alpha of 0.81, and then we measured the general demands. So the general demands have been like staff shortage, staff overload, compliance with regulations on working hours, compliance with staffing ratio, so loss of income, and so on. So these are examples for measuring the routine demands. And that is the measure we took for agency capacity. So we developed a measure called agile capacity, and you see it's for these four functions we used for every function we used 2 items. So, for example, for the adaptation we used the first 2 items here on the slide. For the goal attainment, the next 2 items. And for the integration, we took 2 prominent items of the social capital scale we developed. And we also used 2 items to measure latency. For example, we have excellent knowledge management, or we feel it's very important for new employees to internalize the values and attitudes of our care facility. So that was our try to measure this HR capacity. It's really a short measure. And this HR concept deserves more, a better measurement. But nowadays, it's always really difficult to get people filling out a questionnaire. So we are trying hard to minimize the amount of questions to ask. So the Grombach's alpha is quite good here, and you see here we asked over 4,000. We contacted over 4,000 facilities manager. We get here in the end, in the first cycle, 500 facility managers, and in the second cycle, at least about 300 people answering the questions. So I don't want to bother you with these points. Perhaps these are the results. The results shortly. I can better present this slide, where you see on the left side the pandemic-specific demands, and you see the on the y-axis and on the x-axis we have the HR capacity from 0 to 100, and what you see here is that the pandemic demands have a bit risen up between the first survey and the second survey, but it was not related to the HR capacity. So the capacity, these basic resources of a healthcare organization didn't have an effect on the pandemic-specific demands. But if you look on the right hand of the slide, you see the general demands, and what you see is that between the first and the second survey, the general demands have increased, but only for the healthcare organizations which have less HR capacity. For the ones with high HR capacity, so the rise in the demands have been stopped. So, and that was our main result. And what's also good to know is that the HR capacity has grown up between the first survey and the second survey. So we can say that HR capacity is not a stable thing. It could be, I would say it could be triggered to get up. So the discussion is, so we have the demands on nursing home have increased from the first to the second survey cycle, especially the general demands. And the agency capacity did not decline, but even increased between the two survey circles. Because the question was, Colleen, that does, for example, if we look at social capital, if we look at trust and on the we feeling and the solidarity between the people in a healthcare organization, one thing could be the case that the crisis puts the solidarity down. But the other thing was more true. So in times of crisis, people stick together. That's basically the result here, that if you look only at the eye, so the trust is going up and the we feeling is, and so people are more good together. But my proposition, but we couldn't test this, is this is only possible in healthcare organizations where there is at least a minimum amount of trust. So if there is a minimum amount of trust, that what would be my hypothesis, trust is going up during crisis, but it could be the case that in healthcare organizations where there is low trust, that things are deteriorating because they have not the basis for getting together during crisis. There should be some form of basic solidarity and social cohesion within the group. So yes. So, and we realized that the HS scar was significantly associated with the perceived general demands. Yes, and so we have also to look at the limitations. We have only a repeated cross-sectional design with different participation rates. So that's it's quite weak if you think about that. Then we have a selection bias caused by leaders who felt more affected by the pandemic. The participation is higher in this case, and we got perhaps lower participation rates of top managers who have really been in time pressure during this time. So and the results are not really representative of all LTCOs in Germany, but we try to reach them all, but we can be sure that we were really representative. And for reasons of anonymization, the present study was not a panel study. That would be, in my opinion, one of the biggest limitation of this study. So this study gives only a hint into this direction, I would say. So the conclusion would be that the agency capacity, especially the agile capacity, could be interpreted as a potential preventive factor with regard to routine demands. In my opinion, the question is why didn't we have any significant correlation with the non-routine demands? And my guess is that the non-routine demands, there is no knowledge about how to cope with the non-routine demands with COVID, and so there is a learning curve there, and I think the people are able to cope with known demands if these demands are rising up, but they are not really familiar with coping to non-routine demands. And in this special case, COVID, there is no real grip on it. There is less knowledge about how to get rid of this virus. And so that could be an explanation why these general resources are good for diminishing the normal demands, but not the non-routine demands. That's my, yes, yeah, I can close this. Thank you very much for your attention. I appreciate a discussion about this.